right, so that got us kicked off at least with the first of our two keynote speakers. And I do want to thank Dr. Masters again for joining us and recording that for us, given that he is in such a very, very different time zone from us. So now we will follow that up with a live keynote where you all will be able to interact with the speaker and have questions and dialogue with him after his presentation. His talk will be on precision learning, precision education, and big data to drive decisions around that. So a related but different topic. Our speaker is Dr. Martin Pusic, who is an associate professor of pediatrics and emergency medicine at Harvard Medical School. He serves as senior associate faculty for Boston Children's Hospital and scholar in residence for Brigham Education Institute, Brigham and Women's Hospital in Boston, Massachusetts. He's also director of the American Board of Medical Specialties Research and Education Foundation. Completing his pre-med studies in physiology at the University of British Columbia, Dr. Pusic went on to receive a medical degree from there as well. He obtained a Master's of Arts in Medical Informatics from Columbia University and received a PhD in Cognition and Learning from the Teachers College, also at Columbia. He previously served as an associate clinical professor, emergency medicine and pediatrics at NYU, following a series of faculty positions at Columbia University, University of British Columbia, McGill University, and Johns Hopkins Children's Center. In addition to his academic roles, Dr. Pusic also held a wide range of clinical appointments in emergency medicine at each of those institutions and is board certified in pediatric emergency medicine by the American Board of Pediatrics, for whom he has served as a board examiner. Welcome, Martin. We are very, very happy to have you here, and I will turn things over to you now. Thanks.
You're still muted.
Well, we're not hearing you, Martin. Not sure if there's a...
Is it because of the headphones?
I don't know, it might be.
Okay, I'll try it without the headphones. Can you hear me now?
Yep, now we hear you.
Okay, good.
All set.
Down. So what I was saying was, before I share slides, I thought I'd just a couple of quick observations. One is just to point out how remarkable it is that a South African who works in Oman, whose sphere of influence is in Europe, all of those Amy guides, is presenting to us in America. Kind of the that just is remarkable to me, and so that independent of the time zone difference, I think something to be really celebrated. I'm coming to you as Greg laid out a bunch of kind of my weird background of making my way through academics, but the key thing I highlight in the perspective I'm going to bring to you around this precision education, the way AI works, is as a clinician first off, and then but a clinician educator who at one point was the director of student assessment at NYU, and so had to worry about the data and the assessment and how good are our students. And so that I'm going to try and merge those two particular things and think about kind of your mission along those lines. And then the last disclaimer is that I asked ChatGPT what I should wear when presenting to an august national organization of physical therapists, and it suggested that I put on my best suit and tie, and so here I am. And so that I'm not wearing shoes, so that maybe I'll look myself that way. But okay, good. Well, let's so I'm going to get into the slides. Can you just confirm, Greg, for me that you can see the slides? Yeah. Okay, great. And so what I have just some disclaimers, and so that so I get salary support from the American Board of Medical Specialties, where we worry about research, and basically a thank you statement. You're going to see research from the University of Toronto, collaborators at the University of Toronto, the University of Illinois at Chicago, and at NYU, and I already gave my reflexivity statement of kind of where I'm coming from in terms of presenting to you. This is an outline of what I propose to do. So 30 minutes, 15 of it on data and how that has led to the precision education imperative. And then some stories around artificial intelligence. What I'll try to do is take what Dr. Masters presented just now and think about it at the coalface of being a clinician. What I love, love, love about this setup is that usually the way this works is that you give an artificial intelligence presentation, it slices, it dices, it's going to change our whole world and all of that kind of stuff, and then a 3-minute disclaimer that there are some ethical issues, and then you're done. And so what I appreciate is that we've talked about the ethics and laid that out in all its gory, kind of monstrousness. And now let's, kind of as clinician, use this dangerous technology for the good of our patients, which is what we do. And so that, and then I appreciate the time that we'll have for discussion. And so that I propose to respect that. So this is a task in my world, okay? So these are 18 emergency medicine residents learning how to read ankle x-rays. And these are their individual learning curves as they practice over 250 times. And what this looks like is a you make the call type of thing where we show the ankle x-ray in all its views, and then they have to put a yellow dot on any fracture they see or declare it normal. And then we give them feedback, and so that they get a green check or a red X as to how good they are, and they're meant to learn. And so these learning curves of each person as they go across give us a sense of their pathway through this kind of standardized thing. What's remarkable is how different they all are. That black line is an average of the 18, and it's nice and smooth and moves across, kind of the way theory predicts that you would learn. But each one of the people, kind of has their own march through this, and nobody has the lived experience of this smooth black line as we go forward. And so my claim in this talk is that precision education is this higher ambition to use as much data as we can to go out there and find these people on their particular learning curve for their thing, and then be able to bend that curve in a productive way so as to make learning more efficient and more effective. And so in saying that we're going to use data to do that, there's a basic pattern. And this basic pattern is, in essence, the scientific method, kind of since the Enlightenment. We observe and collect some data, we then interpret it, and only after having interpreted it do we act. And what's changed, and I'll give some examples now, is this big data. We can observe larger amounts of data. We can analyze those larger amounts of data with sophisticated analytic tools like algorithms and artificial intelligence. And then increasingly, our systems are digitalized, and so that we can act on that data within a digital system. And so that in terms of the large amounts of data, kind of there's been a kind of a gradual shift in our lives. And so that we spend more and more time interacting with data. And so in this middle column, what I've done is laid out, kind of what happened in traditional epidemiology land when data was scarce and data was expensive. And so you had to really, really think hard and be purposeful about your data collection. It cost a lot of money and it was really intrusive when you did that. And so that so because it was so expensive, we would only dole it out in quarterly or annual reports, and those would be static reports that reflected backwards. And we would try to get away with the smallest sample size we could to be able to make some generalizable claim. Well, in a big data world, that's very, very different. And so when Amazon tracks you across your shopping pattern, it costs it 2 cents a year to do that. But that data has $1,700 worth of economic potential. And so the intrusiveness is low, the data acquisition cost is low, they're continuously monitoring what's happening on their database. And so that they have an up to the second dynamic dashboard of what's going on in a way that puts to shame the quarterly reports and the annual reports as you went across. And so their sample sizes are huge because they can sample everybody and not try to interact with just kind of small biopsies, if if you will. And so that so the claim here is that we can use that in the health professions for good. And so my radiology example, we can track exactly which views the person looks at for how long, sort of how many seconds do they do. We can put eye trackers on them and see where they're looking. And then we can have the exact XYZ coordinates of where they put those yellow dots and use that in our modeling to predict what's the best next X-ray for them to look at. In surgery, video now allows us to break down where the hands are in 3D space and what's a needle driver, what's their proximal phalanx, and so on. And so that so all of this video data can be put into an AI toaster to make up digital kind of fingerprints, if you will, of each of different procedures, and how good am I at it, and how efficient are my motions in bringing about the desired surgical outcome. And so that there's these new sensors in essence everywhere. And so that so I've got an outdated example of a Fitbit, but the point is kind of now we can track every single one of your heartbeats, let alone every single one of your steps. And how do we use that tsunami of data as we go forward? And so that so the kind of the field of engagement is this. This is the NYU topology of the medical school, and sort of up top here are all the learning management systems, the student information system, the exam system, and so on. And so all of the digital systems that we have. And then we're increasingly able to link them with the electronic medical record, the practice network, and bring them into a clinical data warehouse that we then connect to our education data warehouse and be able to do the lovely things of connecting all of this data all the way through, and also the nefarious things that Dr. Masters was talking about in terms of identifying people all the way out into the electronic health record. And so that so with these sensors, part of our generation's job is to put these sensors where they should be. And so that so where do we collect data from our learners? And part of the competency-based movement is indeed designed to collect data at the coalface, and in terms of workplace-based assessment, and to move the data collection out to where the care is happening, as opposed to doing it just in the classroom or in some kind of artificial area as we go across. So in terms of, kind of I've made the claim that there's lots more data. Now, how do we interpret it? And this is where some interesting terminology comes forward. So learning analytics refers to the interpretation of a wide range of data produced by and gathered on behalf of students in order to assess academic progress, predict future performance. And so that this word predict is really, really important and part of what's changed, and then spot potential issues. And this is from the US Department of Education 15 years ago, or whatever that is. And so that so this trend has been going on for quite some time. But when you more recently in health professions education is this notion of precision education, and basically this definition is the same. Use a whole bunch of data to find the person where they are, but with an emphasis on the individual, who move the locus of control out towards the person who's learning, because that's where it's best situated. And so so what that does in this shift, this secular shift from traditional to big data collection, is it says that instead of us teaching to the mean with standardized education, which is our best guess for how people should learn ankle x-rays, we can now go out and find somebody on their particular learning curve and adapt the education to them. And so that when we think of data, and we go from a feedback scarce environment to a feedback abundant environment where we can have a feedback happening all the time, is sort of within our digital environments. And so the last bit, and I'm going to just, in the interest of time, not spend too much on this, but you could spend a lot of time, is that you can act in this digital environment. And so you can this is my macro example of a structural equation model in the United Kingdom of all the exams that a doctor writes from high school, A levels and O levels and that kind of thing there, through to the final exam that you do, which is an oral exam to become a specialist physician. And so that what's kind of fascinating about this is the sheer amount of data that's in this. This is tens of thousands of people, but also the insights that you can have. So it was kind of the men did worse, the men did worse, the men did worse, the men did worse. And oops, when it comes to the oral exam, just before you're going to become a physician, men do better. And so that isn't that interesting. And so that, and then similarly, not being white in 1990s, and I do not have up-to-date data on this, but all of these numbers have negatives in front of them. And so that to the point that Dr. Masters made in his talk, these negative numbers can be something that we hammer away at from a systems standpoint. And then we can surface this as we go across in a macro sense. And my micro example is dermatologists deciding whether or not to biopsy a melanoma. We can come back with exact measures. Each one of these lines is a different dermatologist, and this dermatologist biopsies everybody, and this dermatology biopsies almost nobody. And so that variation is fascinating and is a great educational target. And so that we can train this digital flashlight or precision education flashlight onto our learners and then use that data for good with all the caveats that Dr. Masters put out. So this basic pattern, I think we do well to recognize what's happening all around us and then to think about that as being within the remit of what an educator does. So that's the precision education part of this. And now what I'd like to do is spend 15 minutes on some artificial intelligence stories that bring to light some of what Dr. Masters was saying and some of what we're talking about here. Now, generative AI influences all of this landscape, and so it depends on having huge amounts of data. Its main role is to analyze that data and move it forward, and then increasingly this, you can think of an AI system reading the ankle X-ray, and so it's moving into this act phase of the whole thing. And so the way I thought to present this to you is to look at a day in the life of a clinician educator. And so I'll talk a bit about teaching didactics and using these things, talk about virtual cases for your residents, and then clinical care. I think, kind of we need to role model using these things. So I'll tell you a story about that, and then we'll finish by reflecting on what all of this can mean. Now, the kind of listening to me talk is nowhere near as good as the experiential learning of you going out there. And so so I'm not going to go through this in any detail, but if you leave this talk and on the weekend, just inventory for yourself. Have you played with ChatGPT? Have you played with Open Evidence, Research Rabbit, and Google Notebook LM? And so that if you take those four, you will have kind of a range in 2025 of, kind of the things that I predict could be useful to a knowledge worker in general, and probably in your knowledge work as a physical therapist. And so and especially Open Evidence is for clinicians. You need an NPI number. You all have that. And so that's what it takes to sign into that. And the idea there is to make this thing smarter because clinicians use it as it goes forward. And again, there are ethical debates to be had, but for now, kind of this is the field to play with. So I gave a talk like this to the neurologists, and when I was preparing the talk, I kind of revisited my own PTSD around learning neurology, and I set myself the task to learning the circle of Willis, and so that's that vascular structure at the base of the brain, and as a medical student, this just would not stick, and so I had a devil of a time, and so I went through to kind of learn it. And I think it's a really good example. And part of what I stress here is that in ChatGPT there are actually two innovations. And so one innovation is the generative pre-trained transformer, and that's the idea that this thing can generate pictures, it can generate text, it can generate new text that was never there before, and so that's the output, and that's what gets all the credit. But part of the thing is that you can interact with it in your language, and you can have a conversation with it. And so so I think we under recognize the influence of the chat part of it, especially when we're teaching this. And so so in a ChatGPT session, there's an iterative chat. You say something, it says something. You say something, it says something. And that's very, very different from Google. And so when you search Google, you put in some terms and Google spits out some standard answer. And then its standard answer, and then you refine the terms, and then it spits out a new standard answer to the refined terms, and so on. And all the learning is happening by you. What's different in ChatGPT is that you do something and learn, and it does something and learns about your issue. And then you do something and learn, and it learns some more. And so that as you go back and forth, you're both converging towards the right answer, and it's trying to understand you as you go along. This is a fundamental difference. And so that too often clinicians come to ChatGPT thinking it's a Google and doing repeated searches as it goes across instead of leveraging the iterative nature. This takes practice, and so that you have to think about how to do that. And so that I'm not going to show you the full session of my, kind of circle of Willis thing, but in it, I think really, really hard about the prompt. And I ask it to say, kind of for all the arteries of the circle of Willis, tell me what the effect would be clinically on the person. And so that it goes and names all of the arteries and gives me answers that are plausible in general. And so so then I say to ChatGPT, well, create a table and compare and contrast each of the vessels in terms of the signs and symptoms that an embolus in that vessel would do. And so it generates this lovely table with tick marks that you would be pleased to see on Consumer Reports. And so that one problem, though, it makes mistakes. And so that one of the mistakes is that, kind of nowhere on there is the notion that your mouth would droop in terms of, kind of an upper motor neuron lesion and the like. And so that, so it's only, as Dr. Masters said, it's only as smart as the internet, and the internet's only so smart about circle of Willis strokes. And yet you can see the potential of this for you educating and creating didactic sessions. And so then I told it, now generate typical 50-word case summaries of a person presenting with an embolus at each vessel. And so it does that, and I can get it to rinse and repeat infinite number of times of all of these cases. And so that, so again, the drudgering of writing cases has been evaporated. But similarly, kind of having your learners think in terms of cases and think specifically in terms of what did ChatGPT get right and what did ChatGPT get wrong, and bring it forward is a beautiful 2025 exercise. So in the question and answer, Dr. Masters pointed that out. You need to teach differently in terms of didactics, and you need to fold ChatGPT into it and specifically fold where it makes mistakes. And so because we're all going to learn about that mistake horizon as we go along, and I think that it's really, really important that you be the one building that into your instructional designs and building in how to manage that as you go forward. And so, so for fun, I then, kind of, it was making mistakes. And so that I'm thinking, well, that's a problem. And so, hey, ChatGPT or DALL-E, draw the circle of Willis for me and show me what you're doing. And so that I don't know about you, but my circle of Willis isn't a perfect circle. And so that that ain't right. And my circle of Willis doesn't have a Doric column in the middle of it made out of some kind of porcelain that, kind of supports the whole of the circle of Willis. And then if you zoom in, each of these things are gibberish. And so that has nothing there. And so we're a ways away from the right thing. But you can see the potential of generating cases and the whole bit and moving it across and it being useful to us. And again, the argument here in didactics is to play with the error horizon. And so I really, really like this flow diagram. It's from UNESCO. I'm completely willing to share it afterwards. But this was put out by UNESCO's Department of Education, and basically it answers is it safe to use ChatGPT? And so the first thing it asks is, does it matter if the output is true or not? Well, for you and I as providers, that's always true. So we're always on this yes side of the thing. Then the crucial question, do you have the expertise to verify that the output is accurate? Your learners do not. You do. And so that for your learners to use this in clinical care, no, not you can't do that, but you can. And as long as then this next one, are you willing to take full responsibility, legal, moral, etc., for missed inaccuracies? Well, again, that's what you and I do for a living. You make a diagnosis, you implement a treatment plan and the whole bit, and you're taking, because of your license, full responsibility for everything that you do along those lines. And so then if you're willing to do that, then it's possible to use ChatGPT. And so that this, kind of, do you have the expertise to start with? And that's where, kind of that de-skilling thing causes us pause around the future. But, kind of this imposes the discipline on us of taking responsibility for our outcomes. Okay. Virtual cases for residents. And so I, kind of hinted at that, kind of within the didactics, generate cases based on blocking the circle of Willis. But this chat plus GPT thing, the chat interface makes for really compelling virtual cases. And so what you can do is create something called a custom GPT where you, the educator, create this orange or spend time in this orange or interacting with ChatGPT to build a learning space for your learner, which is the blue. And so that you do your session to build the set of cases, and then within that, the thing that you built, the learner plays. And the learner plays over and over and over again till they exhaust and learn, kind of with the particular topic. And so my topic, and I'm not going to read all of this, but is ChatGPT, pretend you're an 8-year-old with high fever, sore throat, and difficulty swallowing. Don't tell me the specific diagnosis, but let me ask you questions and elicit physical findings that could lead to an appropriate management plan. And then ChatGPT says, sure, I'll simulate the role of an 8-year-old. And now I start pretending I'm a medical student. What's been going on? It gives me an answer generated de novo. I ask a question with my natural, whatever the next question I would ask in terms of a chat, and then it answers with, kind of an appropriate answer that's in light of the diagnosis that it's hiding from me. So I ask the next question, next question, next question, so on. I ask about physical findings. It gives me vital signs that are appropriate to it in the whole bit. This turns out to be a peritonsillar abscess, and all of these things line up with a peritonsillar abscess. And so so it goes through, and at the end, it can give feedback on the way I ask questions and what questions I might have missed as I went across. And then when I'm finished, I can rinse and repeat. Go do it again for give me another one. Viral pharyngitis. Give me another one. Kind of cervical lymphadenitis. Give me another one. Retropharyngeal abscess. And so it can go through this whole learning space of fever, sore throat in an 8-year-old, and the person can iterate and iterate and iterate in a tireless fashion with the thing. So again, it requires engineering by you, but it's this really, really, for those of us who for a lot of years have tried to create virtual cases with branching logic and the whole bit and created these clunky, lousy things, this is amazing and a deal breaker. A colleague at Beth Israel, did a randomized controlled trial of doctors using ChatGPT ChatGPT alone versus doctors alone, and found that ChatGPT alone did better than the doctors, and then paired ChatGPT with the doctors and figured what they would get is something up here, and instead got something down here. And so that this, though, I think is because of this problem that the doctors here were using it the way you use Google, and they haven't had the faculty development to really leverage what ChatGPT gives you. And so that, again, kind of learn this skill because it's a separate clinical skill, I would argue. Okay, so just let me bring this home, kind of the story I give of being a clinician. I'm a pediatric emergency doctor, and kind of when ChatGPT broke in November 2022, I, kind of a month later paid for a subscription so that I was use it, kind of that I will, you tell your wife that you're going to lose 5 pounds by such and such date, kind of figured by paying it, I would be more likely to use it. And then went in on a shift and said, kind of this shift, I'm going to start using ChatGPT and we'll see what happens. And so on this shift, in came, eventually a patient that was on griseofulvin that they had bad ringworm of the scalp. And so I needed to prescribe griseofulvin. And griseofulvin is a lousy medication. It comes in all sorts of forms. It has to be measured out. It gets given umpteen times a day. It has to be given for a month. And then if you got some response, then you go for another month. Otherwise, just stop and you think like it's a mess in general. But as a special bonus, the patient only spoke Haitian Creole. And so that I had to, kind of explain all of this, and we have a lousy discharge summary type of thing. And so to make a long story short, I type in, kind of, will you create discharge instructions for griseofulvin for somebody with these details? And back came this beautiful discharge summary in English. Okay, now translate it to Haitian Creole. Back comes something that I can't translate, I can't verify. But then I say, without using the initial text, translate this back to English and show me what you've written. And so I go through, and again, I have the expertise to be able to tell whether it's making mistakes with the griseofulvin, and it had not. And so so with some confidence, I kind of scrape off the thing, and then have the go through it with the kind of screen interpreter and the whole bit. But the gist of it being that discharge instruction was way better than before. And so now, kind of all of the little, kind of borderline questions I have open evidence open on the thing, and I use it in the way I used to use UpToDate, but it's more tailored to each person. And so that if I need a culturally appropriate diet for a Syrian American child to help with their high fiber needs for, kind of their abdominal pain, then back it comes with the right foods. Or what are the convalescent exercises for a sartorius muscle strain? Kind of back it comes. Now there, I don't have the expertise to do that, and so that I count on you. But but you get the idea is that you, in the same way as you can individuate the learning for my learning curves that are all over the place for the learners, you can individuate your care based on the idiosyncrasies of your particular patient. And so again, I'm not going to go through this in detail, but for clinical learning, when you have a learner at your elbow, you can use this thing to deepen their knowledge either setting them up well before they go in to see the patient and priming them on what should you ask for a chief complaint of lower abdominal pain, versus checking their differential diagnosis, understanding the medications, thinking about the mechanisms of what's happening, and then, kind of why do we do what when we investigate and what are the limitations and so on. And so so again, as an educational tool in the clinical environment, this thing can work really, really well. And I think that we should explore and start to structure ways of using it. And again, I teach this thing. And so they have this flow diagram there the whole time so that they're thinking about the borders of it. And so the last thing I'll leave you with is that this is an educational opportunity to not only worry about those details that I've gone through, but also to model how you adapt to technology. And so we as clinicians, the people that we're going to train, are going to adapt to disruptive technologies 7 times over the course of their careers in ways that you and I could not imagine. And so that this is the first of the ones that they're going to soak up. And so that the Ken Masters predictions that you've heard are going to come down the pike for them faster and faster and faster. And so one of the key things that we can teach is how to deal with that sort of adaptation. And so that I actually teach the Gartner hype cycle. And so that the innovation comes in, we go to the peak of inflated expectations, we overreact on the upside, and then we overreact on the downside into something called the trough of disillusionment. And only then do we do the hard work of figuring out what works for whom, when, and so on. And we start to do the research as you go across. And so that so every technology is going to go through some version of this, and the hype does not get us off the hook to dismiss the thing, because it could well help our patients. And so that so wading through this is part of our job. And so so I, kind of in terms of this, I like to show these two gentlemen, kind of on the left is Abraham Verdesi, who wrote Cutting for Stone and is a humanist professor at Stanford and is a huge proponent of the provider-patient relationship and the power of touch and the kind of cultural traditions that we have built up. So on the one hand, saying you ain't never going to replace me in terms of care. And then on the right is Vinod Khosla, who is the CEO of Sun Microsystems, who said that in 10 years' time, we won't need any doctors. And so that the technology would get so good that that we will not be able to bring it across in the way that chess can be played better now by the machines. The truth is going to lie somewhere in between these gentlemen, and so that and how that plays out is interesting. But I think we need to have the debates, and congratulations to you for having this session and bringing it across from that standpoint. And so so in the end, kind of, I think it's going to play out that there's a certain benefit to thinking about the kind of average and standard and how to teach ankle X-rays and not leave them all out in terms of they're out at sea with their own kind of thing. But at the same time, kind of that we have to model, kind of control of a precision education intervention as it comes through. And so in summary, kind of think about this pattern of observe, interpret, act, and think about what has changed as is since in recent years and why that's different. Think about your role in the topology, and so that in building these sensors and building these analyzers and bringing them forward so that the locus of control is in the right place for our patients and for our learners. And then the third thing being, kind of create these learning spaces using ChatGPT and think about the affordances that can bring us, that can improve learning as we go across, but at the whole time thinking about that danger zone, that error in that error level and how you cope with it as you go across. And so I'll stop sharing there, and then Greg, you let me know how we proceed from here.
Yeah, so first, thank you, Martin, for a terrific talk, and what a way to get us started for our topics tomorrow. You actually touched on virtually every one of our sub-themes that we have coming at our audience tomorrow, so I think that was a great warm-up.
I hate it when somebody does that to me. So.
No, it was perfect, actually. It was great. So I'll open up the floor now for questions from our audience. So if you guys, the participants, want to raise your hands and ask questions, you are able to unmute and ask Martin any question that you like. While we wait for our questions to come, hopefully we get some interaction from the audience here. I'll go ahead and start with one question, and that is, at NYU, you have the data education warehouse that you described, and certainly at, I think, well-resourced universities, those things can happen, and I imagine they don't happen cheaply often. But what about other smaller institutions that aren't maybe as well-resourced, or even large institutions that may not be as well-resourced? What sort of strategies could you give us that might allow us to sort of dip our toe into the area of precision learning and big data?
Sure, perfect. And yeah, that NYU story is a happy accident. Kind of the first person at the medical school who started, kind of tracking student data on a computer was a microbiologist whose lab was there, and so he used his computer to do that. And Marty Nakbar, and then his computer just happened to be inside the firewall of the hospital. And so as it became more and more sophisticated, he got better and better at it, and the like. They just grew it from his computer inside there, and so everywhere else, it's the university that would do these courseware things for the medical students, and so that there was this firewall and ditch between the university and the hospital, and all sorts of complications and arguments and the like. And the other part that was great at the NYU story was that, kind of the medical school's IT budget was a rounding error on the hospital's IT budget. And so if you can arrange that for that little, kind of asymmetry, that would be good too.
Yeah.
And but more practically, in terms of what you've described, I know of the Canadian example of developing a consortium.
Mhm.
And so no one of the schools could do this, but they started having regular meetings during some of the Canadian national conferences, and had the IT folks from each medical school get together and say, kind of how can we data share, how can we bring things across, and the like. And so that and in doing that, they were able to develop the Elantra Consortium, and kind of work out industry kind of issues, and bring things forward that way. So that's one thing, is to band together as best you can. And then the second one is to, despite the fact that you don't have the dollar figure that NYU does to bring it across, is to still think in terms of a map. And so that what's the map of my learning organization, and what are the arrows that go where, and which one arrow would make the most difference today for my students as they go across. And so that Google Forms within, kind of people have done creative things along those lines in terms of bringing things across from the emergency department into the medical school in terms of EPAs or milestones assessments or what have you. And so kind of take the first baby step and paint the room out from the corner, to butcher some metaphors, but kind of start that way with an idea of kind of that all information systems can kind of eventually get built according to an organized map.
Great, thank you. So we have a couple of questions in the chat and the audience. So Kaylee, I'll call on you first.
Thank you, Greg. Hello, Dr. Pusic. It's great to listen to your talk. I was looking at the Gartner hype cycle and thinking, like, there are some really, really important things that could come from this graphic. And I was just talking about it with my husband, who is a futurist. And he said, if you overlay that with the Dunning-Kruger effect model and with the tech adoption model, you'd have some really interesting integration there. And I was thinking about that in the context of my students, who think that it's insane that I even know what ChatGPT is. And yet they are using it to cheat, which I feel is a complete waste of their time and the technology's capabilities, when they could use it to learn so much better. So I was wondering if you have any ideas on how we could potentially bridge the gap with our students on it. I don't know, just trying to express to them how it's so much better to use these tools to learn than to not learn.
Yeah, thanks. This is one of my kind of favorite bugaboos around this, is that we have used this to other the students, me versus you. You cheat, I am the anti-cheater, and kind of we go across, and that just reinforces a power dynamic that is not helpful. And especially not helpful in the sense that, as you said, kind of if I, kind of have 30 years of clinical experience and you're just entering the field, then, kind of the delta in terms of clinical knowledge is huge. And therefore, kind of you have to work that delta in. And so that the Dunning-Kruger effect suggests that the control should be with the person who has 30 years of clinical knowledge, and they should decide what the student needs to learn. But when we have November 2022 level knowledge, both of us, kind of fumbling forward to try and figure it out with no, kind of oftentimes the students having a better sense of it because they've had, kind of more discretionary time to work away at this thing. It is crazy to take, kind of a format that, an authoritarian, power imbalanced, you're cheating kind of format to that. And so that kind of when Ken described, kind of the way he teaches in his master's programs, that's what we need to do. One of the best that I've heard was a high school teacher who assigned an essay, kind of the way you would, and ChatGPT could write the essay. And so what this high school teacher said is, I want you to go to ChatGPT and have ChatGPT generate the first version of the essay. And so, and then download that into Word, and then I want you to track change improvements to that essay. And so I'm going to mark you based on the delta between how good the ChatGPT essay was and what the final outcome. And in that way, again, you've used ChatGPT, you've felt the error border of ChatGPT, so you've taught the limitations of this technology. But you've now sort of said, I acknowledge the drudgery of the first draft, and so, kind of, you don't have to do the, kind of the the mental effort of that, but let's spend your time making the thing the best outcome that you can. And so kind of the notion of co-production, of us partnering to use this technology well. And so when I do clinical work, it's, how do you think open evidence could help us here? And then we fumble through. And in that fumbling through, we bring as much evidence to bear on our patient's issue as we can. But also we're getting smarter with each and every cycle of that as we go forward, but together in ways that are mutually beneficial.
Thank you. Scarlett.
One more thing before we launch
sure.
into that. On the Gartner hype cycle and the thing, we have a paper on that in which we took the Gartner hype cycle and then joined the Rogers diffusion of innovation curve. And so that if you look up researching innovation and my last name, and it'll pop up, and you might send that off to your husband and see if it jives.
Thank you.
All right, Scarlett.
Thank you so much. I guess my question is, we know a lot of students are using AI and familiar with it, and, the need for faculty to, present it, engage it. What is your advice for how to go about faculty development, and especially maybe from the program perspective? Of course, we always have early adopters and late adopters, but how would you recommend, from your perspective, kind of offering that?
Yeah. I don't have a good answer. And so that I have not seen great examples of this, partly because the notion of AI and, kind of my day in the life thing is just, kind of an acknowledgement of I could have, used AI in all sorts of versions. And so that it's all sorts of applications, if you will. And so it's not one thing that you learn once and you get your 3 CME hours and then you're certified and then you go off to use the thing. Instead, the way I use it clinically for griseofulvin is different from the way I use it clinically for the differential diagnosis of abdominal pain, is different from the way I use it to generate a lecture and specify learning objectives and so on. And so that so each of those require a different way of learning. What I do recommend is that you, as a community of practice who solve similar problems, just have sessions that are akin to, you know, kind of stupid computer tricks, in which you share, you know, kind of the way you've seen it work, and the way you've tried it, and the way it's failed, and the way it's succeeded, and bring it across. And so that, so I think it's a little bit that Jeff Bezos notion of get out there and make mistakes, but make mistakes that are within safe environments in which, you know, kind of you have created the guardrails using your expertise to make sure that you don't truly make a mistake. But at the same time, you can laugh at, you know, kind of its differential diagnosis of blank, while at the same time thinking, wow, I didn't think of this 17th thing that it came back with that that you had not foregrounded. So I'm sorry to have a complex answer to the faculty development question, but the you know, kind of, because I think it is you know, a wicked solution that has multiple aspects to it. But if I was going to choose one thing, it's that Google, this ain't Google. And so that, so think about that chat thing and the prompt iteration and what has to go into a prompt, and at least have a sense of, you know, kind of how you can make it smarter as you go across. And that, you know, kind of underneath everything is a commonality.
Great. All right. We have two in the queue, so I'll go with Peter.
Thank you, Dr. Pusic, for a great presentation. I was listening to Ken Masters talk about wanting to request the algorithms behind the function of the different AI models. And there are tons of AI models coming out at a rapid pace that are now more specialized, like you had the open evidence one, and I've used the research one as well. I'm wondering what your thoughts were on Ken's thought about that. When I heard him say that, I thought, boy, I wonder if I got the algorithm, would I even know that that was a good algorithm? You know, so I'm wondering your thoughts about his approach to understanding the algorithms behind that, and kind of what I would do with that information.
Yeah. I think when you're at the level of Ken and you're internationally influential in terms of the way you bring this forward and are going to drive policy in the whole bit, that his demands for as much transparency as is possible are appropriate. And and that we as a society need to learn how these things work. And so that on some layer, nobody's going to tell you how physical therapy works, and you're going to tell them what is a good answer and what isn't a good answer. But at the same time, you know, kind of, it doesn't, you know, in service of our patients, we need to work with them to say, here's the standard, go ahead, go do your best. And if, you know, kind of, I showed that randomized controlled trial where the physicians lost to ChatGPT. And so that, so if we lose over and over again in some defined context, now that was written cases on pieces of paper and, you know, kind of thing. So it's a narrow context. And I claim that I still do a better job in the pediatric emergency department than ChatGPT will. But the day it does a better job than I do, then I fold. And so that, because for our patients, we need to, you know, kind of do the exact best that we can. And so that, so if it's able to predict with 95% accuracy, and we don't understand how it does that, but it does it, it's successful, then in the same way as I don't really, you know, kind of, I just need to know that my car's internal combustion engine isn't going to blow up as I go down the street, but I don't need to know the technical part of that. And Ken, you know, kind of alluded to that, you know, they call it just the technical stuff, but you know, kind of ultimately, it's not going to be me who judges the technical stuff. There has to be safety and all those sorts of things from, you know, kind of others who are more germane. But if the predictions are so good that they're better than I am, then, you know, kind of, I think that that we need to fold that in terms of how we go forward. And so that, in a sort of bottom line answer, I think that transparency and the whole bit, to the extent that we can, are good. But at the same time, good tests to say, you know, kind of what is the role with our patients is going to be, you know, kind of really the defining thing. I often say that we as health professionals are disproportionately important in terms of this debate. And the reason that we are disproportionately important is, one, you can't argue with the, kind of the social good of what we're trying to do. And so that so it isn't kind of a trivial, kind of does the thing play chess better than somebody else. These are people's lives, people's functions, people's quality of life. And then the second thing is that we have a multi-generational experience with using dangerous technologies for patient good. And so that some brave person decided to use methotrexate to treat eczema. And so that methotrexate has all sorts of lethal, kind of side effects. It's used as a chemotherapeutic agent in the whole bit, but it works in this other application that you might think, kind of isn't a great use of a dangerous drug. And yet for a sufferer of eczema who's, kind of really, really severe, this could be, kind of really, really important. And so that they did that within IRBs, they did that within careful studies, they did that within, kind of that slow slope of enlightenment in terms of trying to figure it out and gently tiptoeing to the, kind of a utility horizon. But they were able to do it, and they were health professionals, and they were able to bring that across. And so that those principles that we learn in the health professions, I then argue we should pull back into society and say, here's how you do this, and bring it across.
Great. Let's see. I thought Bish was there, but I think you lowered your hand.
Thanks, Mike.
Are you ready, Bish? Are you?
Oh, I'm passing.
Okay, all right. So there's a question here from Steve. Steve, go ahead.
Hello, thank you so much. That was a wonderful, wonderful talk. I want to get to an issue, and it's a bigger one in a sense. It's called truth. And one of the things that I'm always finding
Not
fascinating.
like the little issues we've been dealing with.
Right.
Okay, good. Yeah. Okay.
So I'm going to start off with, I saw a play many, many years ago. Lily Tomlin played 8 different characters. And at one point, she's a homeless woman, and she's like, well, what is reality? It's a collective hunch. My issue is nowadays, we don't have a collective hunch. I mean, if you type in vaccines and autism, you're going to have some people saying one thing and you have other people saying another. Is this eventually going to be able to get to what most people would say a collective hunch of truth?
So let me show you a slide I skipped over. So that,
all right.
So that let's see. Okay, so this article is from The Guardian in August 2024, and I'd suggest that you in particular read it. And so that because I think it's exactly this. It's AI in our collective sense of reality. And the reason I showed the kind of my favorite spaghetti plot without the averaged standardized thing in the middle is this loosening of everybody gets to learn in their own bubble, kind of sort of like social media now, right? And so that everybody has their own echo chamber, and there is no centripetal force coming back to some standardized notion in my trivial example of learning ankle x-rays. And so that so this quote is I'm going to read it, is kind of, we are living in a time where truth is unstable, shifting, constantly in contestation. Think of the embrace of conspiracy theories, the rise of the anti-vax movement, or the mainstreaming of racist pseudoscience. And here's the part that I think approaches your kind of really fundamental question. Every age has its great loss. For modernism, it was the coherence of self. For postmodernism, the stability of master narratives, my thick black line through the middle. And now in the 21st century, there's an increasing pressure on the notion of a shared vision of reality. And so that there, kind of the thing is that if we blur the line between, kind of what's our intelligence, what's AI's intelligence, and bring it across, there is a danger that we will, kind of each have our own versions of reality. And that's probably true already in terms of constructivism and the like. But that these tetherings to social structures that we need in order to support, kind of our societies and the whole bit are in danger. So I don't know if that gets directly to your question, but the I don't think anybody can get directly to that question.
Thank you. Yeah, and I, for one, am glad that you went back to that slide. So I'm happy to see it. We have time for one more question. So Alan, I will give it to you.
Oh, thank you, Greg. Hey,
Alan,
Doc.
do me a favor and just put your hand back up because then I can see you. Otherwise, you disappear.
Sure.
Oh yeah. Keep your hand
Hang
raised.
on, let's see, react. Here I am. Can you see me?
Lovely. Thank you. Yes.
Okay, great. Well, wonderful presentation. Thank you. I'm just curious, while you guys are discussing, I also put in Google AI, how would how would you teach or how would you use ChatGPT in physical therapy education? And I also put that in for a neurologist or neurology or pediatric medicine. And AI spit out few differences and few similarities. For example, case scenarios or patient education or study material or personalized feedback. And I really like what you said about personalized feedback for student learners and also faculty learners together, learning this new technology. Where would you say would be the low-hanging fruit for us to kind of investigate more further as we go through this weekend? And where would you say also that we need to be mindful of in terms of kind of staying away or just we don't have enough data yet to be not jumping in, too fast? And I'll leave it at that.
Yeah, thanks for that. I think the where to jump in, I think it's that the notion of you're gonna make mistakes. There's gonna be, kind of places that you go that it was useless, like it didn't help, it didn't add value, it didn't do anything along those lines. But at the same time, kind of there are places where it's going to really, really help. And so that Notebook LM, the Google thing, you put in 3 articles and then say, kind of summarize these 3 articles, and it'll do that in a way that in seconds, in a way that had you read every word of every article, then, kind of you would have been pleased with this outcome. And then on top of that, you can say create a podcast that explains the 3 articles, and then the podcast will, in a woman's voice, man's voice, woman's voice, man's voice, kind of debate the thing and bring it forward. And so these sorts of affordances that are so different, but allow us to take a huge amount of information and boil it down, I think are going to be really, really helpful. And the 3 articles, by the way, are chosen by you. And so that obviously a neurologist is going to choose different articles from a physical therapist, different articles from a pediatrician. And so that specificity that you're looking for will be available, kind of within the way it brings it across. The other part of it is, again, I salute you, kind of in having the AI talk first, or the ethics talk first. And so that, so create that umbrella and debate that. And so that use the, kind of ethics of AI to teach AI. And so that, kind of should I use it with this patient? And so that to what extent, kind of that UNESCO flow diagram, hammer that home in terms of bringing it forward as well. When you say, are there places we should not go? I don't think we know enough to know that. And so that, kind of there's a great story initially where a lawyer took their ChatGPT notes into court and used them and then lost the case for their client and was appropriately, I think, thrown in jail or fined or whatever it is, kind of thing, because that was irresponsible. But irresponsibility already exists, right? And so that so I think again, kind of overselling these things would be an error. My read on it is that we're underselling them. We're kind of there be dragons is true, and everything that Ken says is true. But to use that to say, I don't need to engage in the way that I can say, I don't need to be on X, I don't need an Instagram account, I don't need that. That ain't true for a knowledge worker. And you are all knowledge workers. And so that so some engagement with this is going to be useful for you in your professional lives. And it's only a question of, kind of what and how. And that's the part that that you do need to engage with in conferences like this.
Thank you.
Well, thank you again, Martin, for a terrific conversation and talk and getting us kicked off for our weekend. I will also, you mentioned sort of the idea early on of a consortium to help build big data repositories and drive precision learning in institutions that may not be well resourced. And so that idea of a consortium reminded me about the International Advisory Committee on Artificial Intelligence, that is this international sort of megasphere, I think is the way it's been described, of multiple organizations that have banded together to really sort of grapple with a lot of conversations around the use of artificial intelligence in health professions education specifically. And so I've put the link to their webpage in the chat. If you guys want to take a peek at it, you can see what all they're working on. They have a number of frameworks already developed around health professions education, specifically medicine, but it is so adaptable to many other professions as well. So to see what these broader international organizations are working on in this space around artificial intelligence, specifically in health professions education, is to me inspiring and also a driver for change, and really gets me excited about what the potential is. So thanks, Martin, for everything. And I will turn things back over now to Karen. Thank you.
Yes, thank you so much, Martin. Wow, just perfect way to get us started here and really give us lots to think about, lots to sleep on before we come back tomorrow. And a big shout out to Greg. Greg went to a conference last summer and heard Martin and Ken speak, and was really inspired, and then reached out and was able to negotiate and get them here today. So really thank you all for taking your time and being here. We did record, we have the recordings of Dr. Masters, and we did record Martin's presentation and the Q&A, and we will be posting it because I know there's a lot in there. And I know myself, I want to go back and watch it a couple times to make sure that I really can really think about many of the ideas that were presented there, and look at some of the curves and follow up on some of the other articles that were presented. All right. Also, we once again had an opportunity for all of our participants to, share in some of the conversation here, both while they're while participating in the actual event, as well as sharing some presentations, some pre-recorded presentations. We had 3 submissions, and they are linked in the information that I sent you with the links to the session here today. And they're really exciting. Several of our colleagues are already using AI and shared how they're using it in the classroom. And so again, great opportunity to think about how you might use it in your classroom or in your teaching application. And so tomorrow we have a busy day. We will start at 11 a.m. Eastern time. And we have it broken into, we have 3 topic areas. Each one will start off with some speakers. And after the speakers, who will sort of get us again, sort of grounded in the topic, then we will break out into some breakout rooms. We'll use some small group discussion. We'll have some guided questions, and then we'll come back together for some large group discussion. The 3 topic areas are teaching with the AI, integrating AI into the curriculum and learner competencies, and administrative applications of AI. And at the end of the day, then we will have one final session where we can really think about, all right, what are those questions, and things, where do we need to go from here? And really sort of pull it all together. And maybe there's some action items that come out of that discussion. We'll see, what we come up with as a group. So that is tomorrow's session. A few reminders. Don't, make sure that when you're in the waiting room, that your waiting room name is one that we recognize based on what you are, so that we let you in. Some people use other names that are not recognized, and then we might be a little hesitant to let you in. Remember, it's normal Zoom things. I'm going to mute yourself unless you're speaking. Again, we will be recording all the presentations tomorrow as well, and they will be posted on the PTLI website as well. What we won't be recording tomorrow is the conversation. We want to make sure that people feel free and open to share their concerns, and so we will be actually recording it. I take that back, for our use potentially, as we might want to revisit it to really think about writing a white paper, or you're doing something else with that information, but we'll only be posting the recorded or the presentations from tomorrow's sessions. Again, raise your hand, get in the queue to speak. We do want to make sure that everyone gets a chance to speak. So we ask that you limit your comments to 2 minutes, although that's really never been a problem. And you'll notice that we did dismantle the chat during the speaker's presentation so that everyone can really focus their attention on listening to the presentations. And I will enable it again when we engage in the conversation. But in the past, the chat has sort of taken on a life of its own. And it's been almost like there's a live conversation and there's this whole other conversation happening in the chat. And I know in myself, I struggle with paying attention in the moment as well as in the chat. And so as much as possible, we encourage folks to engage in the live discussion and really limit the conversation in the chat as much as possible. All right. And again, we will have that opportunity at the end of the day to talk about any topics that we missed throughout the day, or really to sort of pull it all together. And once again, just want to thank our gold level sponsor, Rehab Essentials. And again, thank Martin and our innovation team, and certainly Jennifer Green Wilson as our president, for being here today. So that concludes our presentation. And we will use the same Zoom link tomorrow. And so we will see you all bright and early tomorrow morning. Thank you very much for your time and attention.